I'll be basically showing how do you basically in the clinic do an evaluation for an nystagmus. This is not including of any kind of video histopathology or something. What information you can get with the basic clinical examination in the clinic for these patients, and how do you, because your classification into congenital, physiological or acquired depends upon your clinical evaluation. At the same time, you will know which direction to go next, whether it's simply physiological or acquired. So I will give a broad idea about this, and this is very important because for a heart problem you need to do an echocardiography, right? So for clinical evaluation, all the waves are seen, but we cannot still perceive everything. That's why the video nystagmus is still required. I just want to begin with this case. This is diagnosed as a case of nystagmus. What you can see here is child is putting this thirsty movement to the right as well as to the left. So what exactly is happening? This is not a case of nystagmus. This is a typical case of saccadic initiation failure, otherwise called as congenital oculomotor epilepsy. So this is not typical nystagmus. You can see that he puts his head thrust movement to see this because he cannot initiate this saccadic movements. And the second thing I want to show here is sometimes in the clinic you may not be able to see this thing, and this is given by the parents because at the home what they examine, they can give you some video clips. I will play it again for you. You can see this a small downbeat nystagmus. You can see this is developed at 1.5 months of age. With the clinical examination you may not be able to get, but sometimes it's worthwhile looking at the videos. And this is courtesy of Ramesh. You can see the head nodding typically, which is seen in this patient with lot of head nodding with nystagmus. And this is typical nystagmus, which is not a physiological one. You can see that left gaze is more than the right gaze, and up gaze and down gaze, the direction is not changing. So I just want you to see this video. So basically three things you need to answer, whether the nystagmus is physiological. If it is not, you need to realize whether it's congenital or acquired. These three things have to be made sure before you diagnose the patient. And with the infantile, there are different causes for this thing, which I will not go into the details. And with the clinical classification, you need to also know the manifestation and pattern of manifestation, whether it's manifest, whether it's latent, whether it's manifest latent. Sometimes you might have to do even slit-lamp evaluation to get this latent nystagmus or a manifest latent. Without that, you may not see these micro movements and the direction, whether it's horizontal, vertical or rotatory, and the pattern of movement, whether it's jerky or pendular. With the clinical evaluation, I would start with age of onset, complaints, oscillopsia, vertigo and blurred vision. These are important things. Mostly takes you towards the acquired etiology, history of squint or strabismus, any systemic illness, and also occupational history as well as family history that you take in many patients. Head posture. As soon as the patient comes to you, I think this is one of the most important things you need to look at. And squint and strabismus evaluation, extraocular motility. Sometimes strabismus as well as nystagmus evaluation can go hand in hand, and a thorough ocular examination and a comprehensive evaluation is definitely required. What answers you need when you begin? And specifically talking about nystagmus here and keeping aside the strabismus part. Is it seen in primary gaze or is it gaze evoked? Second thing is whether it's jerky or pendular. What is the amplitude? How much it moves, whether it's fine or coarse? What is the speed, whether it's slow or fast? What is the direction of fast component? And the other question is whether it's conjugate or disconjugate. And where do you see the null zone? It can be in right, it can be in the left facing, or it can be in the primary position. Effect of or examination of the slit lamp. This is again important to pick up the serrated nystagmus. And this is the simplistic way of drawing this. If you want to draw and if your colleague wants to see what's happening over a period of time, what is the follow-up. You can see that this is the low frequency. The length of this line tells you. You need to have your own nomogram to document this. It's not that this much is this much amplitude. You need to have. And this is the frequency. If you put more lines, it's high frequency. If you put less lines, it's less frequency. You can see the direction of the arrow. This is where the fast component is there. And upbeat and downbeat. And if you have circumrotated, you can put this rotation marks there. I want you to see this video here. Can I have the mic, please? So it's just showing that whether you need to make sure whether it's a jerk nystagmus or rotatory. This is a typical jerk nystagmus. You can see the small amplitude which is seen with a higher frequency. The frequency is a little bit large, and there is a slow movement to the right and fast movement to the left here. And you can also classify based on the etiology, whether it's physiological, pathological. This is typical end-phase nystagmus. This is an optokinetic nystagmus with the drum, you can see that. And the pathological nystagmus, you have congenital as well as acquired. There are some differences of opinions in this. I'm talking about the basic thing. Can we have a mic, please? Probably I have to run this without the mic.
Downbeat nystagmus is a drug nystagmus with the fast component downward and the null point in updates. And in general, it is associated with good vision and normal neurological findings. More commonly, downbeat nystagmus is acquired, and the lesion is usually at the cervicomedullary junction. In upbeat nystagmus, the fast wave is upwards. Commonest site of lesion is the verbis of the cerebellum or the brainstem when nystagmus is present in the primary position. If present only in upbeat nystagmus is most likely to lead to drug toxicity. In contrast to the mixed patterns of nystagmus seen with cerebral vestibular disease, nystagmus that is purely torsional is indicative of a central lesion. Torsional nystagmus is usually associated with medullary lesion, such as cytopenia or a lateral medullary infarction. This video has provided an overview.
Okay, I will just end with another video. Here, this is opsoclonus again, courtesy Dr. Eamer. You can see the irregular erratic movement of this ball, which is very fast, and also you can see a typical update. Okay, I think I'm done. So I will just end with this two videos, maybe if I can. This is a typical periodic alternating nystagmus. Suddenly the patient changes his head position. He was fixating with the right, and what you can see is a seesaw nystagmus. He has a midline defect there. It's a typical seesaw nystagmus, what you are seeing there. And this is one thing I want everybody to have an attention here. You can see the nystagmus on the right face and the left face. Compare between the right and the left. It's fast moving on the right face. This is on the right face, and compare with the left face. So this is difference in the frequency and amplitude. I can show it once again. See the amplitude and frequency on left case now, and see the amplitude and frequency on this is again on the left case. This is on the right case. There is a significant difference. So she did not have any nystagmus in primary position, and these are subtle signs. This is called Brunn's nystagmus. Typically, you need to image them. They will have a typical tumor in the cerebral contact angle. CP angle tumors are correlated with Brunn's nystagmus. And this is superior oblique